Good morning, students. Professor Krueger here with the first exam. I spent a whole lot of time on it yesterday, and I'm very proud with what I came out with. It's really going to match up with your syllabus. It's going to match up with the stuff that I talked about in class, and more importantly, match up with what is in your book and what NCLEX will test you on. Because the main thing here is that, we get you through this class and then get you on to take NCLEX and pass that. So welcome all my LPVN 101 medical surgical students. We're off to a very good start this semester. I'm so proud of everyone. With that math test, everyone did amazing. I think we are safe to say that you are safe and okay to pass meds at your clinical. So always use safety first. So going on to our exam review, this video is about our Unit 1 and 2 content. I put it into a 50 question test, and each question is worth 3.5 points. We're probably going to give you an hour to do it. When you take NCLEX, you really should be going at a pace of about 1 question a minute. That should be your pace. And just some helpful NCLEX tips. Of course, when you are presented with 4 answers, typically you can eliminate 2 of those answers right away. As long as you have a good base understanding of the material and you've been doing your studying and listening to me, you should be able to grasp and build a good base. And so when you're taking NCLEX, out of those 4 multiple choice answers, you should be able to eliminate 2 of those pretty confidently. And that's one thing about taking the test too. You have to go into the test confident. And going into it confident means that you studied, you put in the time, you put in the effort, and now you will get the rewards of passing. So that's a really good feeling when you can see the results of your hard studies, being able to pass the tests and get a good grade. That is a good indicator of if you understand the material. And one of the things that I was thinking about last night with taking the test, I said last week that our greatest learning experience comes from when we're actually doing it, on the job, and we're getting that life experience. That is one of life's greatest teachers. But I found that, when I'm teaching you and when you take the test, when you're taking a test, it's you synthesizing all the information I gave you, connecting it all, and you're learning. So when you're taking this test, I want you reading, even if you think the first answer, one of the 4 answers, if you think the first one is right, read through all the answers. Read through all 4 answers. Look for the key words in the question, and then match those keywords up with the keywords that are in the answers. And like I said, even if you think the first answer is the right answer, read all the rest of them, because the test is a learning experience too. You guys can learn while you're taking the test, and I realized when I was taking tests that I was learning at the same time. Yeah, you're taking a test. Yeah, it's anxiety provoking, but you can still learn from the test. And this is like you solidifying, cementing that information within you. So, all right, going on to the test. Here we go. So one of the first things in chapter 1, we definitely wanted you to know the role. Know your role. As the LPN, you are a leader, you're a delegator, you are a caregiver. Remember when I talked about in lecture that as the caregiver, you are passing meds, you're doing treatments, you're doing ADLs, and then also the collaborator, being able to collaborate with the CNAs, collaborate with the doctors, the RNs, everyone. You need to be able to collaborate. So those are the roles that the LPN, those are good qualities that the LPN should have. Now, looking at the nursing process, remember I said connect the nursing process with ADPI. And what is ADPI again? Assessment, diagnosis, planning, intervention, and then evaluation. That is the nursing process. That is what you go through each time you meet one of your residents, and you look at them, you collect data. Remember, with the LPN role, assessment links with data collection. You are coordinating with the RN to assess, but you're more or less the LPN role, we are data collecting. And then moving on to diagnosis. Remember what I said about diagnosis. The LPN does not diagnose. So that part of ADPI you can, for now, eliminate from the LPN role. You still can help the RN together do that, but you have to be directly there with the RN. You can't, LPNs cannot diagnose on their own. Planning, planning is where you're coming up with a plan of care. Implementing is where you're actually, so planning, you're making up interventions, you're coming up with things that you can do to help the patient. Intervention, you're carrying it out, and then you're either giving the pill, you're doing the treatment, something to that effect. And then evaluation, you're seeing, was the pain pill I give, was that effective? So you're making sure that your planning and your interventions connected, and hopefully they were effective. That's what you're doing with evaluating. So nursing process, ADPI, you guys don't diagnose. Some of the roles that the LPN can take, mainly the main job placement, place of employment that the LPN has is the long-term care facility. Now, going on to delegating, when the LPN, and there was some question about, LPNs can't delegate. Well, yeah, they can. They can delegate, they can assign. When you think delegate, think assign. You can assign a task to an LPN, to a CNA, or a nursing assistant, but you have to make sure that it's not something where you leave it open to interpretation for them. You cannot delegate a CNA to pass anything with medication in it. That includes pills, injections, creams with medication. You can't allow that CNA to assess whether their butt is red or not. That is not up to them. And the other thing, when the CNA is giving a resident a shower, you cannot let that CNA be the one to assess their skin. You cannot let that CNA data collect on their skin and let them interpret whether they see red areas or not. So every time the CNA gives a shower or a bed bath, you need to be making sure that you yourself, the LPN, is going in there to data collect on the resident's skin. It needs to be you eyeballing it. And that was one thing that, back in my role at the long-term care facility, we were always going back and forth on that issue. And it really is that you have to, the LPN has to go in there and eyeball it. You can't leave that up to the CNA. You can ask for the CNA's input. Oh, did you see something red? And then you follow up and go look yourself. Yes, you can do that. So moving on, patient safety goals. Those are very important. When we have patient safety goals, some of the national patient safety goals are to improve safety. How do we improve safety? Well, we use 2 patient identifiers when giving them pills or a treatment. You always want to improve staff communication. You always want to be open to new suggestions. Don't close yourself off from other staff by, even if you're busy and they come up to you, don't roll your eyes even though you're busy. You have to be able to remain open and keep the lines of communication open. Now, going on with this safety, you definitely want to, if you're available and it's safe for you to respond to an alarm. Oh God, chipmunks. Watch out, guys. You have to be able, when an alarm is going off, if you are available, you have to respond to that. And then the other thing is, sometimes we draw medications up into a syringe, and we have to make sure that when we draw that medication up, that we're drawing it up, in a quiet area so that we can definitely label it. When you draw a medicine up into a label, or you put a pill into an empty cup, if you're going to move that somewhere else, you have to label that medication. So take a piece of tape off, put the medication's name on it, the dosage, and then put it on that unlabeled medication. You always want to make sure that your medications are labeled even when you're transferring them. So, going on, data collection, evidence-based practice. Evidence-based practice is the best current evidence from research. Evidence-based practice is not on social media. It's not someone on social media. It's a reputable source that comes from something like the government or some big nursing or some big health organization, a reputable one. So that's evidence-based practice. Now, always remember with NCLEX, safety first. We're always talking about safety first. You always want to use a gait belt when you're transferring a resident, even if, they feel confident that they can do it. There's always safety first, and use those tools for us. Going along those other lines, if there's anytime you're going to use electrical equipment, like a lift, a mechanical lift, you definitely want to check the battery first. Check to make sure there's nothing wrong or broken on it. There are times when I was in a situation where a CNA comes, and always use 2 people when you're using a mechanical lift. You always want to have more than one person. You got to have 2 people with those big lifts. We're in the middle of a transfer, we have the resident in the air, and all of a sudden the battery goes out. So on some of our batteries, there is a light, an indicator, a battery life on that tells you whether it's low. Always check that first before using that. And there's no worse feeling than having a resident stuck in the middle of the air on a lift and your CNA is running out to go get a battery. Going on to building the nurse-patient relationship. We're dealing with sick people, and a lot of times, we have to be respectful of their culture, their practices, their opinions. Remember I talked about keeping that neutral attitude. It's better to, when these people are cussing you out or something, you got to remain calm. And it's a lot easier to remain calm if you have that neutral attitude where you're not for, you're not against, you're doing your role. Does that mean you're a mechanical robot? No, you're still a loving, caring nurse. But I'm talking about within your own head, it's helpful for you to remain neutral, remain non-judgmental. If someone is praying to a different God than you have, you definitely don't want to be making fun of them. You want to build up that trust, with your patient, especially patients with dementia. You got to get them to trust you. And so that includes, when you first come in there, you're always knocking on the door, you're introducing yourself, you're telling them, time frames, and you're building that trust. You're using good, positive body language. That means you're not leaning towards the door, you're not looking, if you're not, you have to be in front of the residents. With our dementia patients, our patients who are confused, make sure you're in front of them, you're looking at them, you're using a soft voice. And, sometimes you may have to exaggerate your mouth movements. Sometimes that helps. Just don't get too overboard with it, because, some people have taken offense when you assume that they're hard of hearing and you come in there, yelling really loud. There are residents who still have good hearing, and they'll be like, God, don't yell. So, you'll know when it's appropriate if you have to raise your voice. But for the most part, come in there, knock on the door, introduce yourself, build that nurse-patient relationship through trust. Whenever a client is telling you something along the lines of, I don't want to live anymore, I don't feel like my life is good anymore, as the nurse, therapeutic communication, you want to respond with an open-ended question that allows them to explore more of what they are feeling. So if they tell you they want to die, don't tell them, oh, you're crazy. Or don't lead next with a yes or no question. Always when NCLEX is testing you, they want to know that you are responding sincerely and with a question that allows the client to explore more of their feelings. So if you see an answer that says something along the lines of, tell me more, Do you mean this? Explain this to me more. What do you really mean? You want that resident to keep talking, exploring their own feelings, and get them to open up. That's therapeutic communication. Now with holistic care, remember, holistic care includes the patient's whole well-being, their social, their cultural, their spiritual, and their physical needs. Moving on to Maslow's hierarchy of needs, we want to make sure that at that bottom level of Maslow's pyramid, at that bottom level is the basic physiologic needs. And then think oxygen first, airway, breathing, circulation. Those are the needs that come first. So if we ask you to prioritize a resident, say you have 4 different residents who all need something at the same time, you're going to want to prioritize that resident who has an issue with breathing or circulation, airway. Those are all very important. The ability to critically think. That means you have to be able to think on your feet sometimes. You have to be able to have a good clinical judgment and have a good response. And if you are not sure what to do right away, you go and ask someone right away, especially if the situation is a safety concern. You should be able to handle that, but if you feel like you're not just sure what to do, make sure you ASAP go ask someone who will know. And a lot of times our CNAs are a good resource too. You can ask them certain things about certain residents, and they know those residents a lot better than we do typically. Now going on to immobility risks. Remember we talked about immobility risk with the medical surgical patients or people who have developed immobility. So definitely when someone who's at risk for, what are the things things that patients are at risk for associated with immobility? They are at risk for skin breakdown, they're at risk for pneumonia, they're at risk for muscle atrophy. And so remember I talked about, also know the 3 stages of Alzheimer's disease. Remember there's early stage, the patient's still usually walking and talking, there's a little bit of memory loss, they may have trouble doing new things. Moving on to the middle stage, that's where they really start to use confabulation. And if you remember what confabulation is, there's holes in their memory, so they confabulate an idea and use that to make up for their memory loss. So I gave the example of the patient who had a skin tear, and I asked him, what happened to your arm? He goes, oh, this little girl down the hall, she came by and pushed me down. And he was an Alzheimer's patient, and I had to consider that. I had to consider, is he confabulating? Is he making up stories to make up for his lapses in memory? And a lot of times they're not doing it on purpose. It just becomes second nature to them. As their disease progresses, the brain is losing connections. It has to shortcut to confabulations, white lies. So like I said, the things that people are at risk for with immobility: skin breakdown, muscle weight, their muscles become smaller and contracted. They can possibly develop pneumonia. Now, going on, you have to be able to know that when there is a patient who is at risk for an immobility problem, you have to be able to reposition them every 2 hours. Like if someone is in the same position and has not moved for more than 2 hours, you absolutely need to get in there and do some range of motion on them, get a CNA to help you turn them, or you gently wake them and say, it looks like you've been in that position for more than 2 hours. 3 hours is terrible. You definitely don't want to have someone who can't move be in the same position for more than 3 hours is way too long. 2 hours should be the max. especially our patients who are incontinent of bowel and bladder. Those ones that are incontinent, you better make sure we're turning them, we're checking them. No double briefing. Don't you ever double brief. But yeah, you definitely want to be moving them every 2 hours at least. When we are going on to substance abuse, now we're going on to substance abuse. Substance abuse happens among every profession: nurses, lawyers, doctors, teachers. We're all human. Let's remain non-judgmental of these people who have substance abuse problems. And remember that when I talk about DTs, that deals with alcohol abuse. That is someone who is severely addicted to alcohol and they are in alcohol withdrawal. Delirium tremens, DTs, looks like the patient is agitated, they may be shaking, tremoring, as if they don't get a drink soon, their blood pressure and their pulse will continue to elevate. And in DTs, their blood pressure and their pulse can elevate to a point where they can go into cardiovascular collapse. So very important, if you see someone who their blood pressure, their pulse is trending upwards, they're getting more agitated, you start to notice these tremors. People with alcohol, people who abuse alcohol, typically they come in with a GI bleed, something like that. And then once they're in the hospital, DTs withdrawal symptoms from alcohol can show up within 6 hours of their last drink. It can come on pretty suddenly. So know the symptoms associated with delirium tremens, DTs, alcohol withdrawal. Going on to, I want you to know the difference between the two defense mechanisms, denial and rationalization. Now with denial, remember, denial is they are saying they don't have a problem at all. They're saying, and you could present them with all the evidence. Here is a bag full of all the bottles and cans you drank from the last week. You present that to them, they could still say, I don't have a problem. That is denial. Whereas rationalization, they are blaming someone else for their problem. So they're recognizing there's a problem, but they're not accepting responsibility for it. Rationalization, they're blaming someone else. Knowing the physical symptoms of someone who abuses substances, you'll notice that, alcohol, opiates, bath salts, uppers, the physical signs and symptoms of someone who's doing that, they can have an unsteady gait. Their vital signs can either be high or low. They have impaired coordination, level of conscious sometimes. So the skilled nurse definitely wants to be able to recognize physical symptoms, and they also want to recognize behavioral symptoms. So if a doctor is showing up to surgery with slurred speech, that may be a behavioral indicator that he has a substance abuse problem. The lawyer who comes in and is always usually pretty neat, he could be extra neat. Remember I said the other extreme of substance abusers, there could be someone who's looking disheveled, which means they look rather unkept. They're not shaving, they're not doing their hair, their clothes may be dirty or wrinkled. The other extreme of that is there are people who have to be perfect, and they're extremely neat because they are trying to cover up or make up for their substance abuse problem. Does that mean every person who looks neat is a substance abuser? No, but we are looking at the possible behavioral symptoms of substance abusers. Remember, we got to know the difference between dementia and delirium. Delirium, now let's not confuse this with delirium tremens. There is a little bit of crossover, but because delirium, when we're looking at delirium from a cognitive disorder perspective, delirium is very sudden, it's very rapid, it's acute. It comes on very suddenly. There's confusion, a change in their level of conscience. And some of the things that can lead to delirium would be like an allergic reaction, toxicity of a medication within their blood, infections. Someone with an infection can develop delirium very rapidly. It's a very sudden change in this person's normal behavior. Now, delirium versus dementia. Now, dementia is more slow, it's more chronic, insidious. Those are the words that we associate with dementia. Remember, there's the 3 stages of dementia. The first stage may last from 5 to 10 years. The second stage, where they're confabulating, may last from 5 to 10 years. And then the late stage. In the late stage of Alzheimer's, they are usually contracted in bed. They're not moving, they're not walking, they're not talking. They can't recognize any family members. So the late stage is, with that late stage, you definitely want to make sure that you are turning them, making sure that you are keeping them at a lesser risk of developing problems associated with immobility. If someone comes into, now let's go to HIPAA here for a second. Remember HIPAA, Health Information Privacy Protected Act. If a family member can come and ask you for information on a patient, and as long as they're listed as the POA, one of the POAs, one of the protected healthcare agency, an agent of the patient, if they're on that list, you can tell them information. But if someone, even a family member who's on a list, a pastor, a clergy member, a friend, if they ask you to look at the patient's chart, you absolutely cannot let them look at the patient's chart, ever. If they are on the list, you can tell them things, but if someone asks you to look at their chart and they are not your coworker, you cannot give them that chart, no matter how much they beg and plead. With the patient, even the patient too, if the patient asks to see their own chart, typically they have to go through a process and request it. They have to request copies of their medical record. We cannot let anyone who's not on the healthcare team look at that chart. Remember, culturally sensitive things. We definitely want to be culturally sensitive of other religions. If they have religious artifacts that look like they're expensive, you can't just assume and remove it. You have to ask them if we can remove that. Now, it's different if they're going to surgery, and typically the LPN role doesn't deal with people who they're sending to surgery. In surgery, patients do have to always remove metallic objects. It's a sterilization concern, because if someone goes in there and they're wearing their jewelry, that could be contaminated with bacteria, and with surgery, you don't want that getting in there. But if you're admitting a patient and you're doing an inventory of their belongings, if they look like they have something religious or important to them, you just leave it alone. You can ask them, oh, what's that about? But we should be respectful of their things and their culture and their religious artifacts. So never remove something without asking. When we're dealing with death, we do deal with death quite a bit. It's very important for the nurse to know how they feel about death first. I remember I had to take a death and dying class at MATC to be an LPN. So I hope you guys are sure about how you feel about death first, because you have to acknowledge first within yourself how you feel about death before you can go and help someone else and help them cope with death and dying. So make sure you're sure about yourself and how you feel about death before you go giving advice to a patient or family member about death. In a crisis situation, always safety first. When we're teaching senior citizens, typically with the elderly, they already have chronic illnesses, so we definitely want to teach them symptoms management. And then the last few questions are some math. And since everyone passed on that math test, at least for the first couple classes, we'll see about Wauwatosa on Monday. That is our first test, and I hope you found this useful. It looks like I'm right at about 30 minutes here, so I should wrap this up. Maybe some last few tips, just some reminders with NCLEX. Eliminate 2 of those answers. If you have a good understanding, you should be able to eliminate 2 answers right away. That leaves you with a 50-50 chance if it's a multiple choice. And when we ask a question about, we may ask a question that says the nurse this and this, except. When we say except, you're looking for the answer that is different from the other 3. So I give you a question or a scenario, the nurse is this, they do this intervention, those are all good interventions, except you are looking for the intervention or the answer that is wrong or that does not fit. Sometimes there will be a question about the nurse needs more teaching when they state this. You are looking for the wrong thing. So to recognize the wrong answer, you need to know those other 3 right answers. Even if you don't know the answer right away, sometimes you can look at the answers that are presented to you, and if one of those answers is not like the other 3, it's typically that first answer. Go with your gut instinct. When you move on to the next question, move on to the next question. Don't stay thinking about the question 10 questions ago that you got wrong. You are going to get questions wrong, trust me. In the 250 question exam I took to get board certified earlier this year, I probably got a whole bunch wrong. But as long as we're above that 70% mark, that means for every 10 questions, you can get 3 wrong. Out of 10 questions, 3 wrong, you're still at a 70%. So do yourself a favor, tell yourself, yeah, maybe I got that one wrong. Move on. Move on to the next question. Leave that. Leave it alone. It does you no good to sit there and dwell on it and page back to all the other questions you thought you got wrong. Just move on. Trust your gut. So I hope that was helpful, students. Was very happy. I spent a lot of time on this test yesterday. So I'm making sure it matches up with all the teachings in the syllabus. So thank you very much. Good luck on the test next week. I'll